Good day and welcome to the Getting Updated on Multiple Myeloma conference call. Today's conference is being recorded. At this time, I'd like to turn the conference over to Mr. Jennifer Gillette. Please go ahead.
Hi, yes, welcome everyone. Thank you for joining us today. My name is Jennifer Gillette and I am the staff social worker at the National Bone Marrow Transplant Link. I'd like to welcome you and thank you for joining us with our Lunch and Learn with the Link. This month's program will focus on updates and inspiration with multiple myeloma. A special thank you to the Leukemia and Lymphoma Society, Insight Corporation, Pharmacyclics and Janssen, the Omeris Corporation, and our esteemed Link partners for making this program possible. Just a quick little outline for everyone so you know how our program is going to run. We're going to have a basic introduction explaining a little information about nbmtLINK to those who might not know us. And then I will introduce you to Dr. Sherilyn Tuazon, who will share some amazing information about multiple myeloma and what's on the horizon, as well as survivor Todd Brown is joining us today. Then we'll open up the floor for questions for the remainder of the hour. So for those of you who are not familiar with the National Bone Marrow Transplant Link, our mission is dedicated to helping individuals and their families from diagnosis through survivorship. We provide resources, support, and education. Some of the resources we provide to help families navigate their transplant journey are our webinars, our podcasts, blogs, our lunch and learn calls like the one you're on today. And we have these on a variety of topics such as chronic graft versus host disease, disease-specific information, caregiving, coping, treatment options, and survivorship. We also have an active Facebook page with daily inspiration and relevant tips for survivors and their families. We have a peer support mentor program for patients, caregivers, and donors, our Second Birthdays Recognition program, and we also have some great books and referrals, as well as emotional support from a licensed social worker. So if there is any support you need, feel free to reach out to us. Before we begin today's program, I would like to review just a couple housekeeping items. One is please be mindful of trying to be concise with your questions at that time so that we can answer as many as we possibly can today. Also, please know that the information provided in this program is meant to stimulate conversation with you and your own healthcare provider and is not meant to replace your individualized medical plan. So now on to the educational part of our program. We are so very thankful to have our first speaker with us today, Dr. Sherilyn Tuazon. Dr. Tuazon is developing better treatments for people with multiple myeloma. Her primary research goal is to create novel cellular therapies that provide lasting remissions and cures for patients with this currently incurable cancer. Her focus is on blood stem cell transplantation and immunotherapies, such as genetically modified T-cell therapies and a form of targeted radiation called radioimmunotherapy. Dr. Tuazon is also a physician who cares for patients with myeloma and other disorders of the blood plasma cells. So thank you so very much for joining us today, Dr. Tuazon.
Thank you very much, Jennifer, for the kind introduction. Hello, everybody. Good morning and good afternoon to everyone. My name is Sherilyn Tuazon from the Fred Hutchinson Cancer Research Center and Seattle Cancer Care Alliance. It is a very exciting time for myeloma, and in the next 20 minutes, I will review the current information on the role of stem cell transplantation, sometimes termed bone marrow transplant, in the treatment of multiple myeloma, and present what's the latest on immunotherapy in myeloma, particularly chimeric antigen receptor T cells or CAR T cell therapy. By way of background, multiple myeloma is a cancer of plasma cells in the bone marrow and is the second most common blood cancer in the United States. The uncontrolled growth of plasma cells leads to an end organ damage, such as bone and kidney disease. Infection is also a notorious complication and is the leading cause of death in myeloma. And despite therapeutic progress over the last decade, the sobering truth is that myeloma remains an incurable disease. Thankfully, with the use of newer, potent myeloma drugs and autologous stem cell transplant, along with post-transplant maintenance therapy, survival from myeloma has improved tremendously. Patients with standard risk or average risk myeloma can typically expect to live 7 to 10 years or beyond. And what's important to understand about myeloma is that it's a markedly diverse disease, such that each person's myeloma is different. Myeloma also changes or mutates within the same individual through time, which is very challenging. And given the significant heterogeneity of myeloma, it is important to recognize that one size does not fit all in the treatment of myeloma and that individualized therapy is key. The initial choice of therapy depends upon the patient's health, age, ability to undergo stem cell transplantation, and the aggressiveness of the cancer, whether the disease is considered high risk or standard risk. Most patients will be treated with a 3-drug regimen, and one popular regimen is bortezomib, lenalidomide, and dexamethasone, or RVD. After this initial therapy, usually about 4 months, we encourage patients to proceed directly with stem cell transplantation rather than to delay this procedure until the time of disease progression, because transplant, when performed early, results in a longer duration of remission. Stem cell or bone marrow transplantation can be done using one's own stem cells, termed autologous stem cell transplantation, or using stem cells from a close relative or matched unrelated donor, termed Allergenic stem cell transplant. In multiple myeloma, most transplants performed are of the autologous kind, and it remains standard of care in patients eligible for transplant, even in the context of novel therapies. And such transplants, although not curative, have been shown to prolong remission and life in some patients. Autologous transplants for multiple myeloma are very safe in centers with experience in the procedure, such as the Seattle Cancer Care Alliance or any other centers, with a less than 1% mortality rate. Autologous stem cell transplant entails collection of your stem cells from the blood, which will then be frozen for later use. After you recover from the stem cell collection, you're given high-dose chemotherapy called melphalan to kill as many of the cancer cells as possible. Then the previously collected stem cells are thawed and returned to your body. At our center, this procedure can be done on an outpatient basis, that is, without a hospital stay. I will have our patient Todd Brown discuss with you more about the details of stem cell transplant as well as common complications after my session. Another type of transplant that is sometimes offered to patients is called double autologous transplantation, sometimes called tandem transplant. And this involves the use of 2 consecutive autologous transplantations done within 6 months of each other. Double transplant does not appear to offer additional benefit to most people with multiple myeloma, however, in some patients with high-risk multiple myeloma, this is sometimes offered because they have worse outcomes with single transplant or any standard therapy. Allogeneic stem cell transplant, on the other hand, as I mentioned, uses stem cells from a donor with a matching tissue type. In approximately 20% of cases, allogeneic transplantation results in long-term remissions suggestive of cure. Unfortunately, approximately 15 to 20% of people who undergo allogeneic transplantation die from transplant-related complications such as infection and graft versus host disease, which is a condition in which the donor's transplanted stem cells attack your body. Primarily because of these complications, as well as a lack of clear benefit, allogeneic stem cell transplantation is only offered in patients who are young, fit, and have high-risk multiple myeloma. Now, to switch gears, in recent years, we have learned the importance of our own immune system in fighting cancer, and we developed multiple immunotherapies to treat a variety of cancers. And the unique potency of the immune system in myeloma is first illustrated in the allogeneic stem cell transplant setting, where we can see the power of these donor stem cells in eliciting an immune response against myeloma cells. However, as I mentioned, the crudeness of a donor stem cell response is associated with substantial complications and death. So now, CAR T-cell therapy, or chimeric antigen receptor T-cell therapy, is a more specific way of teaching the immune system to recognize and target myeloma cells in an effort to capitalize on the potency of the immune system without having the unique complications we see with an allogeneic or donor stem cell transplant. CAR T-cell therapy involves the use of a patient's own T cells, which are a type of white blood cell to fight cancer. It begins with a collection of the patient's T cells, and these T cells are then engineered to become cancer-fighting cells, called CAR T cells. These CAR T cells are then grown in the laboratory until there are millions to infuse back into the patient. And once infused into the patient, the CAR T cells are now able to recognize and destroy myeloma cells. Chemotherapy, called lymphodepletion chemotherapy, is typically given for a few days prior to CAR T cell infusion. And the most commonly used chemotherapy regimen is called fludarabine and cyclophosphamide. The chemotherapy provides a space as well as favorable environment for these CAR T cells to grow and live in the body. There's currently no approved CAR T cell product for myeloma at this time. At present, CAR T cells are offered in the context of a clinical trial and often for patients who have failed standard myeloma therapies. However, there are several ongoing trials using BCMA, or B-cell maturation antigen, as a target. The B-cell maturation antigen, or BCMA, is a protein that is expressed exclusively on plasma cells, and in particularly large quantities on plasma cell-turned myeloma cells. BCMA conducts signals important for myeloma cells' growth and survival, and it is expressed in virtually all patients with myeloma. A common theme of the CAR T-cell trials is striking response rates among patients with highly advanced myeloma, the majority of whom have had multiple prior therapies and had no other meaningful treatment options. In the largest CAR T-cell trial published to date, the study has treated a total of 128 patients with a CAR T-cell product called BB2121, or Idacil. There were almost 75% of patients who responded to this CAR T-cell therapy, and 1/3 of them had a complete response, meaning disappearance of all signs of their cancer. The median progression-free survival, which is the length of time after treatment that the disease didn't worsen, was 8 to 9 months. And some of these patients have not relapsed more than 2 years after CAR T-cell therapy. These outcomes compare well to standard treatments for relapsed myeloma. As a reference point, patients with myeloma who fail 3 main classes of myeloma therapy, that is, immunomodulatory drugs such as lenalidomide, proteasome inhibitors such as bortezomib or carfilzomib, and anti-CD38 antibodies such as daratumumab, they only have a median progression-free survival of 3 to 4 months. And the median survival is only 8 to 9 months. And in the CAR T-cell trial, the reported overall survival was 19 months. Based on the promising results of BB2121 or ide-cel, an application has been submitted to the Food and Drug Administration for approval of ide-cel as standard therapy for patients with relapse or treatment-resistant myeloma. A decision on the application is expected by the end of this month. So in general, the preliminary results of CAR T-cell trials are very exciting. However, until we have more conclusive results, the position of CAR T-cells in the treatment of myeloma remains to be determined. There are also other strategies that I would like to share with you that are being investigated in the CAR T-cell space. These include the use of other targets on myeloma cells, using CAR T-cells earlier in the disease course at the time when the patient's T-cells are at their superior fitness, use of donor T-cells to manufacture CAR T-cells in order to provide what we call an off-the-shelf product. And at our center, we have a clinical trial that incorporates a small molecule called gamma secretase inhibitor in order to increase expression of BCMA or B-cell maturation antigen. And this is a concept developed by Damian Green at the Seattle Cancer Care Alliance. CAR T-cell therapy is also associated with serious complications that may be life-threatening, and this is something that is important for us to remember. And the most common side effect is what we call cytokine release syndrome, or CRS, which is caused by a large, rapid release of inflammatory substances or molecules into the blood from immune cells affected by the CAR T cells. CRS manifests as fever with or without low blood pressure, low oxygen levels, and organ dysfunction. Another common complication after CAR T-cell therapy is neurologic toxicity, which can be manifested as headache, confusion, speech disturbances, and in severe cases can lead to seizures, brain swelling, or coma. I am happy to speak with you more about CAR T-cells as well as stem cell transplantation during our question and answer portion. Thank you very much for your kind attention, and I will have Jennifer introduce Todd.
Thank you so much, Dr. Tuazon. That was fascinating, and it's so great to hear about some of the work that's being done and that we're so close with all of this is becoming a standard. Yes, I would like to introduce Todd Brown now to you. Todd is a 67-year-old professional forester from Idaho. He is married and has 2 adult daughters. He was misdiagnosed with osteoporosis in late 2011. After a sternum fracture from a friendly chest bump, as he says, that refused to heal in early 2012, he received the diagnosis of multiple myeloma. He is a 2-time stem cell transplant recipient with multiple myeloma, and he will be sharing his uplifting message that focuses on resilience, staying positive, and finding balance post-transplant. So thank you for joining us, Todd.
Thank you, Jennifer. Greetings all. As Jennifer said, I am a multiple myeloma patient. I'm a 2-time transplant survivor. I'm pretty competitive, and in my first diagnosis, there was a bit of woe is me, why me? But then I changed gears. I said, you know what? I'm going to beat this thing. I'm going to hit it head on, and I'm going to take every option that the physicians offer to me, and I'm going to beat the odds. So after some chemo with a local oncologist, I did go to Seattle in late 2012 for an autologous transplant. I went through the chemo and conditioning pre-harvest. I'm a bit of an overachiever, and I was able to produce 36 million stem cells in one sitting, so to speak. The odd thing is that my Hickman was somewhat positional in nature, and so I had to lie completely still for 8 hours in order to get those 36 million cells. Other than sitting there or lying there on the bed, the actual stem cell harvest was relatively benign. I had the Malphilan treatment and then the injection of stem cells after the treatment or the period for the Malphilan to clear my system. Through my caregiver wife constantly reminded me to keep ice chips in my mouth, I was able to avoid any mouth or throat sores that typically infect patients going through Malphilan treatment prior to stem cell introduction. The actual stem cell reintroduction was, again, relatively benign, much like getting any other IV treatment. I will admit that the following week was a bit of a fog. I don't remember a whole lot about it other than being led around by my wife to the appointments and making sure that I was fed and hydrated. And then I slowly started to come back into normal being. And each day became easier, and other than a skin infection due to some surgical soap and surgical tape, I became fully engrafted on day 25 and was able to come home just before Christmas in 2012. I did not tolerate Revlimid as a maintenance drug, so stopped that after 3 months and managed to go almost 5 years before the multiple myeloma cells started to reemerge. I am a non-secretor, so the normal kappa light chains, M spikes, or Bence-Jones proteins do not show up in normal analysis. So I get to have the lovely bone marrow biopsies to gauge the position of my disease. And I've had about 18 to 20 of those lovely procedures. The cancer cells started to come back in late 2018. So I went back on oral chemo, and then in the fall of 2018 went back to Seattle for my second transplant. Did not need to do the harvest because I still had stem cells frozen in the bank. And everyone at Seattle had told me that the second transplant would be more difficult than the first, but neither my wife or I felt that. We understood what was coming at us, and I feel we were ahead of the curve because we understood what was coming at us and we were prepared for it. So I felt that the second transplant actually went easier than the first. I understand that There is no cure for MM. But again, I'm competitive. I'm going to beat this thing as best I can. I've told my grandchildren I fully expect to see them graduate high school, college, get married, and maybe meet my great-grandchildren. I'm not going to let this thing beat me. Looking back over time, I think that having a positive mental outlook has been extremely beneficial to me. I kind of view this as a card game, a poker game. I'm going to play the hand I was dealt, but as in poker, I was able to turn one card back to the dealer and get a new card. And then I turned the second card back to the dealer and got a new card, and I'm going to keep on doing that. The other thing I think that helped me was that I posted often on the Caring Bridge blog site, and being able to explain to friends and family what the medical professionals were telling me made it easier for me to understand the process and become kind of my own advocate. In addition, I think that having a strong and loving caregiver with me every step of the way made a huge step, benefit towards me. The other thing, I think that I'm not sure who does the hiring at Seattle Cancer Care Alliance, but every member of their staff greeted me with a smile, greeted me by my first name even after my repeated visits. And I never met a member that had a bad day. And so their infectious, cheerful attitude helped me maintain a positive mental outlook. And as I've ended most of my conversations, my blogs on Caring Bridge or my emails to friends and family, and I maintain life is good. I'm lucky to be where I am. Life is good. Thank you.
Thank you so much, Todd. I just really appreciate your authenticity, and I love how you compare it to a poker game. I think that's going to resonate with some people. But now I want to ask Jennifer to please introduce or explain to our callers how to call in and have a question. And if you could do that at this time, we'll open up for questions now. Thank you.
Yes, if you do have a question on today's call, that is *1 on your telephone keypad. A voice prompt on your phone line will indicate when your line is open. Please state your name before posing your question. Once again, that is *1 to be placed into the queue. And we'll go to our first question.
Hey, thanks.
Yes, hello. I'm a cancer survivor of multiple myeloma. I've had both transplants, and I'm about 4 years since the second transplant from a donor. My question is, since I've had both transplants, the first one was with my cells. It failed. It did not work. I got one with a donor, my sister. It did work. Is CAR T therapy an option for me in the future if I need it?
That's an excellent question. I'm so happy that you're still responding to your current, to your sister's stem cells, and that's really remarkable. So you're 4 years out now. Are you on maintenance therapy? Excellent. So yes, so at the Seattle Cancer Care Alliance, we're one of the centers who still treat patients with CAR T-cell therapy after an allo transplant. So, yes, you will still be eligible.
Okay. All right.
But hopefully you won't need it anymore.
Well, I'm almost at remission, so to speak. That's what they tell me. But yes. I also know there is no cure for multiple myeloma, and it will come back. And, like the gentleman who spoke recently, it is an experience, and it's a very difficult experience, which I really don't wish on anybody. And I'm just trying to see what my options are in the future if CAR T may work for me. I'm healthy, considering, but you never know. You know what I'm saying?
Yes, I agree. But CAR T cells would definitely be an option for you.
Well, thank you very much for answering my question. I truly appreciate it. I really do.
Best of luck to you.
Thank you.
We'll go to our next caller.
Yes, good afternoon. This is Donna, and I had two brief questions for you regarding CAR T therapy. If a patient can have more than one stem cell transplant, can they also have more than one CAR T therapy? And also, after a CAR T patient is discharged from the hospital, how is their recovery the same or different from the stem cell transplant recovery?
Hi, Donna. Thank you for your question. So your first question is, after CAR T cell therapy, are you eligible for another CAR T cell therapy when you relapse? Is that correct?
Yes.
Yes. So I just wanted to let you know that, yes, it is likely that you would still be eligible for another CAR T cell therapy if the first CAR T cell therapy has failed. However, one trial showed that patients who received a second CAR T cell infusion after the first one has failed only had about 21% response rate. And the responses were much shorter, which ranged from about 2 to 7 months.
Oh, boy. Okay. Good to know.
So the responses are not as robust as the first one, and we still need a lot of work in terms of making these CAR T cell responses last longer, because although we have seen striking responses to up to 100% of patients with really refractory, highly advanced disease, the remission rate is still short at less than 1 year. So we really need more work in figuring out how to make these CAR T cells last longer. And then your second question, Donna, was, I actually forgot.
It's after the CAR T patient is discharged from the hospital, how is their recovery the same or different from the stem cell transplant recovery?
Yeah, for some reason, CAR T cell therapy after, 30 days when we discharge them from our center seem to have a better side effect profile. It seems like most of our patients are able to function normally after a CAR T cell therapy. So the side effect profile is better than a transplant, I would say.
Oh, good. Thank you very much.
You're welcome, Donna. Have a good day.
All right.
We'll go to our next question.
Hi, my name is Alan. I had an autologous stem cell transplant to treat my multiple myeloma about 30 days ago, released from the hospital 2.5 weeks ago. And my question relates to the side effects, which seem to leave me much more fatigued, groggy, stupid, and in need of lying down than after 30 days than I really kind of expected from what I read before. And I don't really have a sense of the historical recovery from those sort of suppressed states of consciousness. Can you give me a better sense of how that fog may lift over time?
Yeah. Well, first, congratulations on completing your autologous stem cell transplant. But I'm sorry that you're still experiencing some fatigue and mental fog. Usually patients recover within 3 months, and the fatigue and maybe the mental fog improves as well. But what's really important is to actually try to do more of the usual or normal activities to improve the fatigue as well as the mental fog. If you can do exercise as much as you can, as well as try to engage with people or try to live normally as much as possible, that could help the recovery. But usually patients feel better within the first 3 months. And I have to say 30 days is still very early after transplant. So although we discharge you to home around 30 days, patients still have some lingering side effects, and that is totally normal. So don't feel discouraged and keep going and stay positive.
Okay, I shall. Thank you.
This is Todd. I would agree 30 days is still pretty early. I would encourage you to exercise, not necessarily in a gym, but just get out, do some walking, get some sunshine if that's possible, play with your dogs, cats, kids. Just be physically active. The other thing that I found was that eating a fairly healthy diet, but yet high in protein, so meats, some of the protein bars, something that will help you get some energy, longer-term energy, not just a spike of energy. But that really seemed to help me get a little more energy, which then made the exercise or walking a little more effortless, which then aided in my appetite. And of course, your immune system needs that protein. So I would do what I can to eat healthy, eat some protein, and get some exercise.
I totally agree with Todd. Yeah, thanks for bringing up the protein component, but it's very important to get in sufficient vitamins, minerals, and protein. Just because some component of recovery is reliant on your diet, especially protein, which is needed for cell recovery or cell repair.
Great. Well, I appreciate your suggestions and information about the time limit. Take care.
Take care.
And once again, to ask a question, that is *1 on your telephone keypad. We'll go to our next caller.
Hello, doctor. This is another Todd, and I was diagnosed multiple myeloma in summer of 2019, manifested through 6 compression fractures on the vertebrae. That's how we found it. So we took care of those, and then did chemo treatments, 4 rounds, and then the autologous, and have been in remission 2 years as of February, with complete negative MRD based on bone marrow biopsies. So resumed all normal activities and levels and participation in sports and things like that. I just turned 61, so I feel better than I've felt in 2 years, and everything's great. I understand also that this stuff comes back, and I'm wondering if with the new advances, we've collected enough stem cells and frozen them for a second transplant if needed. But let's say in 2 or 4 years, get a reoccurrence. Is that still the anticipated procedure going forward, or with some of these new advances, is maybe a second stem cell transplant not going to be necessary?
Excellent question. First of all, congratulations on being MRD or minimal, for everyone else in the call, it's called measurable residual disease negative. It means that Todd is in such a very, very deep response. And patients who've achieved that state actually live longer and have longer duration of remission. So that's excellent news, Todd. What's important at this time, Todd, is that you're on maintenance therapy, because that would keep you in a remission for a longer period of time. And in regards to your question,
and I am, and we actually just reduced it from daily, every day, no break, 10 milligrams to 5 milligrams, 3 weeks on and a week off.
Excellent. And I suggest actually that you're on maintenance therapy for as long as possible and for as long as you can tolerate it, because it's definitely going to keep you in a better state in terms of your myeloma.
It's indefinite, is my understanding at this
Perfect.
point.
Yes, that's correct. That's what we typically recommend is indefinite maintenance therapy as long as you can tolerate. So good job. And in regards to your question about whether a second transplant would be an option for you, I would say in general we offer a second transplant if you've had a great remission from the first one. Usually what we like to say is about minimum of 18 months remission from the first one without maintenance, or about 36 months or about 3 years while on maintenance therapy. And typically what we find is that patients get about half of the remission from the first transplant. Let's say, as an example, Todd Brown, who was our patient guest, had about 5 to 6 years, I think, of remission from the first one. So roughly, in general, he will get about 2.5 to 3 years remission from the second one. And let's say in your case, Todd, if you've had, let's say 10 years, some people can have very long remission from the first one. We can still use a second transplant eventually, and you'll get about 5 years remission from the second one. So I would say it really depends on how much remission you've gotten from the first one before we offer a second transplant. However, like you mentioned, stay tuned because we have a lot more options coming up. So it may not be even the best choice for you to have a second transplant, depending on what we've discovered in the next few years.
Well, it's all very encouraging. Thank you very much. And
congratulations
thank you to
again.
You health professionals that have saved my life and allowed me to enjoy my grandkids. Thank you.
Congratulations.
Todd Brown here. Congratulations, Todd, on your transplant and your remission. The fractured vertebrae sounds almost exactly like my story, and I still stay physically active. Referee a high school basketball, put up hay for the horses, get my wood, do everything I want to do. Keep on the maintenance therapy as long as you can. Do not be afraid of a second transplant. Know that the drugs available today and tomorrow were not available 5 or 6 years ago. I keep believing that while I have enough stem cells for a third transplant if needed, there are some drugs on the horizon that may not make that a requirement for me down the road. So good luck.
Thank you.
We'll go to our next caller.
Hello.
Hello. Yes.
Hi, this is George.
Hi, George.
Hi, George.
Yeah. My spouse carried a multiple myeloma on pancreas and pelvic about 10 years ago. And she's doing chemotherapy, combination chemotherapy, BRD, for 1 year, and acupuncture. Then the tumors disappear. And she have corrected the stem cells. And right now it's already 10 years. She's doing the care for 7 years, maintenance. So she stopped in 2018 February. And right now already 2 years, still in the remission. So in case she need a bone marrow transplant, those stem cells will reserved 10 years. It can be used, can be perform the bone marrow transplant or CAR-T in the future.
Thank you very much for your question. So just to make sure I understand, you were asking whether the stem cells collected about 10 years ago would still be viable or be good for a transplant. Yes, typically at our center or in general, these stem cells are still good for about 10 years. And we do perform some viability testing or we do some sort of just a test to make sure that these stem cells are still good, but the majority of them still are good.
How about the CAR T for use those cells for CAR T?
So CAR T cells will still be an option. Eventually, once your wife, is that correct?
Yes.
Yes, once your wife relapses, it still could be an option, because I think what you were getting at is that when you get a couple of cycles of RVD, it may be difficult to collect your stem cells, but that would be from the stem cell portion. However, it would not affect the way we collect the T cells for CAR T cells.
But she did for the 4th year to collect the stem cell, but she do not do the bone marrow transplant for when she started treatment because response so well, so she do not perform the bone marrow transplant. Right now, already 10 years.
That's fine. She may not even need it if the biology of the disease is very what we call indolent, meaning she's not progressing. She might not even need a stem cell transplant. But it is possible that these stem cells in the freezer are still good or still viable.
Oh, okay. That's good. Thank you. Thank you so much.
You're welcome.
Yeah, 10 years. Yeah, it's done. Yeah, thank you so much.
Take care, sir.
Bye.
We'll go to our next caller.
Hello.
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 Hi, this is Morris.
Morris?
Yes.
Hello.
Hi. I've been a myeloma patient since about 2011.
Mm-hmm.
I found out that I had compression fractures in the summer of 2010. We discovered that it was myeloma in early 2011. I did chemotherapy until October and did a stem cell transplant at that time, and was put on a Revlimid maintenance therapy. Do you hear me?
Yes, sir.
Okay, and put on maintenance therapy, and I was on 10 milligrams of Revlimid, and finally in October of 2018, I had a relapse. Then they did radiation on my T6 vertebrae, and since then I've been back on Revlimid, but they added a drug, ixazomib citrate, and I'm just wondering how long this therapy may keep me in remission.
Yeah, that's a great question. First of all, I am hearing that you've got about 7 years remission from your auto transplant. Is that correct?
That's correct.
Excellent. So, in general, this ixazomib, Revlimid, and dexamethasone, as long as you're responding, then you may be in remission.
Actually, I'm not on the dexamethasone, whatever that is, dexamethasone.
Oh, so you're just on both drugs?
Yeah, on Revlimid and ixazomib.
Okay, and
That's
how
what
long
I'm
have you
taking
been
right now.
on this drug? 2 years?
Since 2018, December of 2018.
So you've been in remission for 3 years using this regimen?
Well, about 2.5 years, yes.
2.5 years. So I would say it's really hard to predict how long you're going to be in remission just from this drug, because every patient with myeloma is different. And that's something we really want to emphasize, because, it really depends on the biology of your disease. And it seems like yours is what we call kind of more indolent. It's not that aggressive. So you could be in remission for a couple more years with this regimen. But what's important is that
I feel good. I feel healthy. I'm able to do just about anything I want to do. I only have maybe once a month I'll have a bad day that I really feel bad, but otherwise I'm doing well. And I was just wondering also if my stem cells that were collected in the beginning might still be viable.
They would still be viable, and actually, since you've gotten 7 years of remission from the first transplant, you can consider doing a second transplant if you wish so. But it seems like you're responding from this current regimen, so it's also fine either way.
I did have a reaction from the melphalan in the beginning.
Mm-hmm.
Yeah, the pre-therapy before my stem cell transplant, the melphalan caused me to have some nerve reaction from the back of my neck. I think it was. It caused my rotator cuff muscles in my shoulders to go numb, and I couldn't lift my arms for almost 6 months. But doing my own therapy at home, running my fingers up the wall and all, getting my arms up. Finally, within a year, my arms were back to normal, but it took quite a while.
That's a very interesting side effect because we haven't really seen that much for melphalan, but I'm glad that you're recovering. And what's important, Morris, is for you to be able to keep a close eye on your myeloma labs, meaning have your doctor make sure that your myeloma labs are monitored at least monthly, because it's very important to catch myeloma at the time of relapse early rather than when it causes problems like another compression fracture.
Well, actually, my doctors check more often, not as often as monthly, more likely at 3 months. Is about what they're doing right now, every 3 months.
3 months is also acceptable. I would say in between 1 to 3 months should be good.
Yeah, that's what we're doing. Okay,
excellent.
Thank you so much.
Excellent, Morris.
Thank you very much.
You're welcome.
We'll go to our next caller.
Hello.
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 Hi, welcome to the call. Sir, are you still there?
At this time,
I'm wondering,
is there...
Okay.
I'm sorry.
Is there any other people on the call?
At this time, there are no further questions.
Oh, good.
Okay. Let's give him a minute to call back if he chooses. But, just kind of recapping, Todd, on those days when it felt rougher than others, what would you say kept you the most positive?
I think that probably some physical activity, just getting up, moving around, playing cards, walking around, something that kept me moving, used up a little bit of energy, kept me mentally awake and doing something, which then caused me to be a little hungrier, a little thirstier. And it's kind of like a snowball. I mean, not going downhill, of course, but the more I did, the better I felt, the better I ate, the more I was able to do. And sometimes I didn't want to move, frankly. I wanted to sit there in a chair. And my wife said, no, we're going for a walk. We're going to do this. We're going to do that. And I get up and do it, and I just kind of kept putting one foot in front of the other. And again, it kind of snowballed. And the more I did, the better I felt. The more I ate, the better I felt, the more I could do.
I appreciate you sharing that. It's interesting that you say the one foot in front of the other, because I've heard from other people going through this the importance of having a motto. And I have heard that exact same phrase used multiple times, that, just one foot in front of the other, or moment by moment. But thank you, Todd. I appreciate you sharing. Jennifer, is there anyone else in our queue? Any more questions today?
Yes, we'll go to our next caller.
Okay, great. Thank you.
Hello.
Hello.
Hi, my name is Stephanie. I'm calling from California, and I have two questions. The first question is that the most difficult time for me through journeying through multiple myeloma and the pandemic is being away, being isolated more from family and friends. And so I have a stem cell transplant coming up in May, and I would like to know how soon after that can I have come over to my house, maybe one or two visitors, and also about how long before I can go out for a walk, because I love to exercise and be outdoors.
Excellent question, Stephanie. So first of all, don't be scared. I know it's very overwhelming that you're going to go through a transplant in May. And it's also overwhelming, especially during this time of COVID when, you can't see a lot of your family members and friends. In general, I wanted to let you know that the peak of immunosuppression is around 3 months, is up to 3 months after transplant. So that's the peak. What's important, though, is that you could get a COVID vaccine around 3 months after transplant, the flu shot 6 months after transplant, as well as the rest of your childhood vaccinations at 1 year after transplant. Also, like you mentioned, if you would like to see your family members, it's fine to see them as long as they make sure that they practice usual precautions, like don't see you when they are sick or having symptoms, as well as hand washing and wearing a mask when indoors, just for the usual COVID precautions. And in regards to taking walks, I'm sure Todd Brown will be able to speak to you about that some more, but definitely you can take walks as much as possible as early as you want after transplant.
Okay.
I would see. Do not be scared of the transplant. Once you're discharged in your home, and you want to see your kids and your grandkids, your neighbors, Dr. Tuazon is correct. If they're healthy, possibly wear a mask, even without COVID. Wash their hands, and just be careful as if they had the flu or a cold or the sniffles. The community, your friends and family around you, that really aids in your mental outlook. As far as exercise, take a walk around the neighborhood. Anything you can do to get outside, get some sunshine, get some fresh air. I would not, head to the mall and walk inside unless the weather's nasty. But if you've got an opportunity to walk outside, just a walk around the block to the end of the street, that's really going to help you move forward both physically and mentally. And then, of course, once you're outside, the neighbors come out to see you. You can, again, without COVID, just kind of watch out, keep your distance as if they had the flu or a cold. But the community support, your friends and family are immensely important. And then that walk to the end of the driveway, the walk on the street is going to be huge for you going forward.
I agree with Todd. And Stephanie, a transplant is more of a mental exercise too. I know there's a lot of, physical, of course, you need some physical endurance and physical strength, but it's really a mental, it's a mental game. So if you could keep yourself positive and really, just think of your blessings and just count your blessings during the process and take it a day at a time, I think you will do wonderful.
Okay, thank you. That is so very helpful. Thank you to both of you. That's encouraging.
Yes,
can I
Stephanie, I think you will do fantastic.
Thank you. Can I just ask one more simple question?
Of course.
I would like to know, what is the standard number of cycles for RVD for multiple myeloma?
That's a great question. So usually about 4 to 6 cycles. We would like you to have at least very good partial response, what we call, or about a 90% reduction from your initial monoclonal protein. Historically, we don't want patients to get about more than 4 to 6 cycles of RVD because we think that it's going to be harder to collect the stem cells, because the more you're exposed to Revlimid, the harder it is to get a target stem cell dose. However, we know that with a new drug called Mozobil or Plerixafor, that's not an issue anymore. So as long as you're responding, we're able to collect enough stem cells from you. But I would say in general about 4 to 6 cycles. Todd is an overachiever and got 36 million, but in general about 8 to 10 million is what we want for stem cell transplant, for two stem cell transplants actually.
Okay, thank you very much.
Best of luck, Stephanie.
Thank you so much.
Well, we have reached the end of our hour, and I want to thank first both our speakers. I feel like you both just did such an amazing job, and we're so thankful that you joined us today. I also thank those of you who asked questions. I think it's good to hear from other people what they're going through, as well as answering those questions here today. As far as our next Lunch and Learn, next month we will be talking about coping with ocular GVHD, so stay tuned. You'll be receiving information about that. And also, if there's any other way we can support you, or if you're looking to pay it forward and try to help other survivors, we can always use peer mentors. But if we can help you, or if you're interested in volunteering, you can call us at 1-800-LINK-BMT. So again, thank you to our speakers, our sponsors, our link partners, and all of you for joining us today. Have a great day.